Hi, welcome to Case of the Day, and we're looking at the 91st case and how many signs of an intramuscular schwannoma can we see here, and therefore is it a schwannoma or not. So this is a 34-year-old with pain in the proximal leg and a positive Tinel sign medially and posteriorly. And that's the focal lesion. It is in the flexor digitorum longus, but it also expands into the intermuscular plane between the longus and the soleus. So if you see here, it does split the muscle, but then superiorly it seems to expand outside the muscle, or maybe it thins it a lot and then just abuts the soleus. The classic signs were well tabulated in this article, and they include the flat split and fat rind sign, fascicular sign, target sign, thin hyperintense rim sign, and the entering exiting nerve sign, which includes the tail sign. We can clearly see the split fat sign, right? And inferiorly, it's because there is splitting within the FDL, but superiorly, it's likely between the lesion, between the flexor digitorum longus and the soleus, and maybe a little bit of atrophy here, some kind of denervation atrophy. But anyway, we have a positive split fat sign. I don't think we see a fascicular sign. We don't see a target sign even, and we didn't see it on contrast. And we didn't see a thin hyperintense rim sign because in our tumor protocols, we rarely do fat-sat imaging. But we had a little trouble with the entering, exiting nerve sign, and I was quite convinced that this was the nerve. It clearly is a muscular branch of the tibial nerve because the tibial nerve is absolutely fine here. It's sorry here. It's not involved at all. Um, and Then we looked at the dynamic contrast and used those properties to identify the artery, the vein, and then we saw the structure here along the superior and inferior aspects that wasn't particularly enhancing and slightly thickened and represents the entering exiting nerve. So we can see that as well, and two signs are present. A third one, which hasn't been documented well, is this one, that in the early phase of the dynamic contrast you see a peripheral enhancing rim with a less enhancing center. If there's a classic target or reverse target sign, you'll see it much better. But this also generally implies that it's a schwannoma, though, as I said, not well documented. That 2020 paper mentioned that if you see greater than or equal to two signs, it's likely an intramuscular peripheral nerve sheath tumor. And the split fat and entering exiting sign were the best to help differentiate, or rather, the entering exiting sign was the best to differentiate from non-peripheral nerve sheath tumors, because the split fat sign can be seen with any intramuscular tumor, nerve sheath or not, as long as it's slowly growing. The target sign, the thin hyperintense sign, and fascicular sign are also reasonably specific, but as you can see in our case, not sensitive. I've done two schwannomas or neurogenic tumors, one a paravertebral posterior mediastinal lesion at bstneoplasms.com. All of this is free to view. And another one was a sacral schwannoma, and again you can see here the target signs, etc., very well. But the question is, should it be biopsied? And given that the findings are highly suggestive of a benign lesion and mostly a schwannoma, if everyone's convinced, the surgeon, the radiologist, then I guess you can go ahead with direct excision, because even if it doesn't turn out to be a schwannoma, let's say it turns out to be another kind of neurogenic tumor, or turns out to be another intramuscular benign lesion, that should be fine. It's always a tricky thing, whether to biopsy or not. But this one has been around. Symptoms have been there for 3-4 years. No significant rapid growth, and the patient doesn't really feel anything much. So it should be fine. But if typical signs are not present, or there are unusual clinical features, then a biopsy is an immediate must. That's the free lecture till the end of the week, my WhatsApp channel. Thank you so much for viewing this.